Hey, it might.
This is now Monica's fans only page for eating broccoli.
It's like it can be an ASMR. Get real close to the mic.
No, it shouldn't be.
You know, it's like overcooked broccoli, so it's going to be mushy.
Well, we're back for, I don't know what number this is. Does anybody know? 17?
I was going to say 18.
It's not 18.
I was going to say 87.
I didn't know we were keeping track.
I'm glad we're all on the same page here. Before we get rolling, we had a question come in from the YouTubes from Keegan Metcalf.
Keegan. I like that name.
It's not going into the Beard family repertoire. Keegan, it's a great name. It's not naming my kids after you. Says, dear farm fam, if evidently he's part of the family. Right?
I love it. Keegan. Welcome.
In a case like your scap functional, assuming for premise of question, when you have a normal person, that's air quoted, doesn't weight train or exercise regularly, who has had an injury that you resolve / begin to resolve with directional preference, movement, re-education, things like you did in this case, etc. How often or how far into treatment are you introducing loading in the traditional sense, like weight training or more high intensity flow activity like rowing, or for your scap patient? It's talking about the one lady that got ran over by a motorcycle, I'm assuming. Essentially wanting to know if you guys push for lifestyle changes in the form of progressing the exercises. Like, I know you won't stop at 5 month sidling, but do you move towards things like kettlebell exercises, TRX routines, or do you stick to increasing their functional capacity as it relates to their ADLs, if that makes sense? No, it makes no sense. Your question is crap. No. Yeah, it makes sense. I guess we're doing not a good job of saying we do that. I guess we're just covering cases. Yeah, that would be the premise of what we're doing here, is not stopping right too soon. We talked about that a little bit last time, like where do we know where to stop? I actually would say that's where we start, is what are they doing that's driving the bus? Do we think something in their immediate environment needs shifting, either to mediate what's going on or prolong better long-term outcomes, right? Like the runner I saw today, like within the first visit, all right, we're going to try to change some function, which should reduce pain. Our long-term play is we're going to try to formulate a plan to make you a better runner based on how we're training you long-term, which should also keep you out of pain. So I would say I'm addressing that almost every time. Now, do we get so specific that it's like TRX routines? No, what I'm asking everybody is like, what do you want to do? What do you do? There's very few people I'm like, you have to do this. That sometimes that happens, but I'm not like putting in specific, like,
here's your rowing
practices.
Intervals that you need to.
Yeah. Like you have to have some like buy-in on what do they like to do versus, like, I was talking to another patient while his daughter was in here, and I was like, you know, as we age, you should lift something heavy one time a week, do 3 to 4 days of like zone 2 aerobic cardio, 1 day of like kind of high intensity interval training, and then have 1 day off. Nobody's doing that, right? Even though that's like the best thing you can do over the age of 40. Like we're going to run a little more, lift more weights, but you kind of play in the middle of knowing what is expected versus what you want to do.
So if you don't mind me breaking that question down a little bit. So he said in there, all right, so you have a patient that clearly doesn't not have a physical activity routine already, right? So they're coming to you kind of naive or green with that realm or that environment. So I would say from my perspective, like Beau just said, I'm not going like one specific area. I'm not pushing kettlebell routines on everybody, but perhaps during rehab, I see that they have an affinity for kettlebells. They like it, or they seem to.
I think you mean kettlebell.
Kettlebell. they or maybe they almost like feel empowered by weightlifting, and that's very new to them. Then I want to set them up somewhere in the community with a strength conditioning foundation.
Eventually we'll be setting them up at our own gym, which really answers the question. That's why we're opening a gym.
Yes.
Because we think it's
did we just announce that to the world?
I think we've talked about it for long enough. I mean, we should be opening one. If somebody wants to set up a GoFundMe page or go to Monica's fans only page and donate some money, we can open a gym sooner. But yeah, that's why we're doing that. So we have a better handoff from active care, functional change over to an environment where if somebody's tentative due to how they got injured maybe, or not having direction, like we have a better direction that's under the supervision of us. So yeah. Any other inputs on that?
Yeah, I mean, that's what I was going to kind of bounce off. I was going to say, yeah, I mean, do they want to do those things? Like,
Yeah.
bro, do they want to do those? And then the other thing that I'll do, especially because I mean, a lot of times, you can get people out of pain and change their function pretty quickly too. And so I'll look at somebody and I'll say, all right, I want to see you in a month, but next time I see you, got to tell me something new that you did activity wise. Mm-hmm. So trying to push them to the point where it's like they realize, hey, I want to keep doing this so that we can keep working on things.
Yeah, I'm with you on that. In addition to that question, so thank you, Keegan. Appreciate it. Hope that answered your question. Keep them coming. Also had a 5-star review. Said extremely insightful. This is from DC Rebs. Says really enjoy this podcast as a chiropractic student. It's been very insightful to hear how other clinicians treat and approach patients in a real life case versus something learned out of a book or scripted as they would at school. Please continue with these.
Nice. Thank you
Wish
very much.
Granted.
Done.
Thanks,
Yeah.
Rebs. Do you think that's like stands for rebels, like DC Rebels, or maybe
No, I
their
think it's
name's
DC
Reba?
Rebounds. I think they're a basketball player.
Okay. All right. Fair enough. Okay. Let's get on to it. I love reviews. More 5-star reviews, the better.
And here we go.
I hope we can get a GIF of the little celebration that Sloan did do when she found out we had a 5-star.
Now we got to debate. Is it GIF or GIF?
We proved it.
Yeah, it's
Did you say definitely GIF?
I think, yeah.
It's
We proved it,
it's been GIF the whole time.
but I would still
Peanut
say
butter.
GIF.
Like, if you don't know,
But GIF peanut butter is a J.
Also, with your accent, I thought you said Jeff. And I'm like, I don't know what you're talking about.
okay,
First GIF? Oh, GIF.
Okay. Am I the moderator today?
Yeah.
Does that mean I take over from here, or I just kind of add some of my great clinical insights?
You're not taking over.
Okay.
You're adding insight.
Didn't I call it my podcast last time?
Yeah, we'll get it, Sloan.
Everyone will be happy to know that my 22-minute case study will not be presented today.
Now she's going to add 10 minutes to each case.
You are welcome.
Does anyone I know Monica doesn't want to get started. She's still eating chicken. She's getting tokens thrown at her on her fans page. So we'll let her roll with that. Do you want to go or do you want me to go?
yeah, I'll go.
Go.
Okay, so this is like a fresh, hot case.
Hot!
Literally 6 o'clock last night. I'm going to go through the history that she said that I think mattered, that she didn't put on her intake, but just kind of hit a lot of high points. So she wrote down on her intake, left side, leg pain, lower back pain. I think everybody who listens to this podcast is probably thinking, derangement city, I'm for sure
I've been there.
going to solve this in less than 30 minutes because nobody wants to be getting home at 7:30 at night. And so that's what I had coming in, and little did I know that for sure was not it. So going further, so she is in her 50s. I do not want to do the quick math to give you the exact number. She is a teacher at elementary school, and 2 years ago she had this is now we're going off her intake form, but 2 years ago she had a gastric sleeve, was her only surgery that she's ever had. And since then, I can't remember her exact number, but I definitely know that she's lost at least like 75 pounds in the last 2 years. So
I'll applaud that surgery or not.
right.
Good.
Well, and I'll applaud the fact that she has continued to eat right and exercise and not just using it as in like one thing.
Yeah.
So 2 weeks ago, she ran a 5K at Oak Mountain and she started to have knee pain. And so me thinking again, this is a derangement case. So I'm going through everything. We finally get to the movement exam. SFMA basically shows nothing other than pain when she squats.
Nice.
And you're like uniform spinal curve, everything. I'm trying so hard to just provoke it really fast, just to be like, all right, let me just go ahead and answer my questions that I have already assumed before this person walks in.
Ooh, error, right?
Right. Which is, and then it kind of quickly shows up that I'm like, dang it, now I have to actually go through everything. So then there is not any kind of directional preference and nothing at all, no lumbar exam that I would normally do that kind of shows me function after doing SFMA shows itself. And I know a lot of times I'll branch away depending on symptoms of how deep I go into the hip or back or functional capacity or something. But so none of those show up. So then for, when I was doing my residency here, I think I only legit saw it once. I've seen Beau actually do a lumbar instability case where it's like, because you just don't normally see this. So I'm like, all right, let's just see it. Of course we do like prone instability tests, and like the only thing that almost reproduces almost all of her pain. And
How soon?
A full extension.
But
So,
I mean, like time, like duration, or just right away?
like she went up into it, and it was like
This is knee pain?
No.
knee and low back pain.
Oh.
So she had knee pain from running a 5K 2 weeks
Yeah,
ago.
that's what I heard.
So the other thing about that with the history is, again, she says that she ran her 5K in Hokas, which I know how the farm feel about Hokas. I immediately am just like, at least I would jokingly be like, all right, I don't really want to care about your knee. I just want to trash Hokas for a second.
I mean, unless Hoka wants to reach out and sponsor this podcast, then we may change our view.
They
Kidding. All right, keep going.
Kidding. We'll still trash it, but you're more than welcome to sponsor it.
Not kidding about that.
So we kind of, I check out, do every ortho on her knee, Thessaly's, everything, and nothing shows positive on her knee. And other than, SFMA did also show her balance was not the best in the world. So right now we have the balance, we have instability, and we have lack of extension. Those are the three things we're seeing. And as soon as I start to coach how to coach and how to move through her lumbar region, like how to stabilize it almost through like classic DNS, we're seeing huge changes immediately, no pain. I'm seeing a lot of dysfunction change. And so I'm just going to leave it at that. So
That was last night.
Yeah, that's where we're at. So
this case brings up an interesting point when we were talking about like the pain audit, functional audit, because the extension tolerance test is both technically,
Mhm.
right? Because pain is what you're looking for if it was a positive test. But then you're looking at, which I guess then you could say, well, I guess there could be a bunch of different things dysfunctionally, right? Like IAP, just loading an extension. But at the same time, like I think that is kind of one of those rare, like one in the same. You know what I mean?
Well, if you have one, I think you're going to have a few of the others.
Yeah. You could very well, I guess it's hard to have adequate IAP if you're loading an extension. But again, I think that's, I guess if you had a spondylo.
or a gastric sleeve,
Yeah.
2 years.
Which is really common to have extension-based low back pain with gastric sleeve. Right? Really common.
Yeah. And was she someone that lost did she have a ton of abdominal adiposity? Is that where you feel like she lost a lot of her weight?
If I didn't ask that.
No.
Yeah. So she was just loaded.
Mm-hmm.
Yeah.
Like almost like that was, I guess, like a protective mechanism before, I don't know, or an offset.
Yeah.
Okay. So in other words, would you say maybe the knee pain was brought on during the run? She had, let's think of a instability in her midsection and then clearly instability in the shoe choice and kind of monkey in the middle.
Yeah.
Is that knee?
Excess range of motion in her hip, ankle. So like, yes, I talked, I guess I left that off. Like, yes, we did a bunch of central stability stuff, but of course we did exercises for her hip, stuff for her knee, things that she can do to quickly get out of any kind of pain. Even gave her like a few things like, when we're talking about like flexion in range, loading with the knee, did it change or do anything to her knee? No, but told her, I go, if you have any pain, I was like, you're not having a current pain driver. I was like, but these are two movements you can try with almost like a half kneeling position for your knee. And so
that's what I had a patient. I mean, Clayton's been there with me that she has 2 kids. The oldest one, I believe, is 4, has had not necessarily extension basal low back pain. She's stuck in extension, has back pain with radicular stuff on the right side. She came in for knee pain, like bilateral knee pain. We didn't do anything for her knees except tell her to get into a deep squat because she has an amazing deep squat. and then worked on central stability. She came in the next time, had no knee pain. She had knee pain for months. And like, I mean, everything was fine with her knees. It's like, she was just like throwing a bunch of like excess work into like anterior chain just because like she's stuck there all the time.
I've got a postpartum patient. She delivered her daughter a day after I delivered Maddox, and she sees me for bilateral knee pain, and it's all central stability issues. We fix that. She gets immediate knee pain relief. It's not forever lasting, but she has a long way to go.
My patient got out of back pain and knee pain and then got food poisoning. And I'm pretty sure has a cervical derangement.
From food poisoning?
From throwing up.
Oh,
now
that's a bless her heart.
Yeah.
Oh,
Well, here's a question for both of y'all. You've been in practice longer than me. So talking about bilateral knee pain, which I think is not uncommon, especially from like how uncommon in the sense of like how much you see it in like central stability stuff.
Yeah.
How many times have you seen it when it wasn't almost like a central stability thing and you knew it, like you're pretty positive it wasn't stenosis, like they're young enough where like we're not really worried about that. Hopefully hopefully no matter the age we've still rolled it out. But what other things have you seen it?
Whenever I hear bilateral, my first thing I've got to rule out in my head is something systemic.
Right.
So I can't think of anything that really I've had in the past that's systemic issue that presented itself as a bilateral knee complaint, like bilateral fingers or wrists, bilateral feet, but I can't think of anything bilateral knee that I've had before. That was like a systemic issue.
Stenotic change, I mean, major degenerative change, which obviously is going to have other things going on with it. But honestly, like how somebody's doing something.
Yeah. Okay.
That would be the biggest thing. Like,
Gymnast, Osgood slaughter. That's like stands out as bilateral knee complaint.
I've had numerous patients, so like just how they're squatting or how they would coach squat. Like you literally look at that and then you're like, well, let's just coach it. And then they have no pain. And then you're like, you may give them something else. Come back next time. I've had knee pain stemming squat. Okay, here we go. All right.
Guys, that brings up a rabbit hole question here is I see a lot, people will say like form doesn't matter. It's just, build tolerance in that activity. But when you can take someone out of the form that they're taught and change it and they're immediately better and stronger, I just don't think the form doesn't matter holds any kind of weight.
Yeah. Then the argument would be, is there right or wrong? Or is it just different? Did you just create novelty? So is what you did good, or is it just different?
I think there's right.
And then, or the other side would also say, has that person not built up the tolerance for that position? Which, and then, I'm kind of always I kind of agree on both sides where it's like, yeah, I think that there's a biomechanics to it. And then it's like, once we learn how to load, then like, let's challenge it and build all the tolerance possible.
Yeah. Goes back to it's never black or white. It's always that messy middle.
Yeah.
Well, none of you see on social media, there is a black and white.
There is.
All I'll say is tendons don't like shear, and you can definitely put a tendon in a shear position that would be deemed okay via social media and other practitioners. I don't care who you are. That doesn't make sense from physiology standpoint. And if I can take a bare bone science and say that it doesn't apply, it doesn't apply. I don't care how much you create tolerance. You're not creating tolerance.
Or build strength. Like you just have to build quad and hamstring strength.
Like, why would you want to build, we talked about this a little bit on the residency last night. Why would you want to build strength around a tendon that doesn't have the capacity? Then you're putting the tendon in a decapacitized scenario, right? Shear strain, whatever it is. And then
that was Seth that brought that to the table,
which
right?
was from another, like kind of journal club, which was kind of interesting, but that's besides the point. Yeah.
All right. Who's up?
You want to arm wrestle?
Is it me? Think I'll win?
She just ate all that broccoli. Oh, it's spinach. It's Popeye spinach.
Yeah. The broccoli's good.
It is great.
Yeah, I can go. This one was in the other day. I'm really unprepared.
This is abnormal for Monica.
This is very abnormal. So I feel really frazzled inside.
You got some sweaty palms.
Yeah, my face is probably getting a little red.
I'm going to grill you super hard.
You're pulling a Sloan right now.
Well, the good thing is that my patient was awesome and brought in this whole layout.
They made that?
She made this. It's a whole spinal diagnosis, back pain. That's what it's titled. And it's a list of clinical information, her symptoms. It says technique, which was all of the imaging that was performed. And then she laid out the findings and impression.
Which also kind of gives you insight to the type of person they are and the psyche behind their ailment.
Yeah. So it's been 7 years
since
2014.
Yeah. So she's I guess you could say pretty married to that.
Yeah.
All right.
And I'm going to have Clayton, if I forget anything, please hop in, call me out. Clayton was with me for this, so it was fun. So 27-year-old female who's super active, likes to run. She used to do CrossFit, not anymore because of the back pain. She climbs, does yoga, hiking. She's in ultimate Frisbee tournament this weekend, I believe. So she's super active. But she has low back pain, central low back pain that started in 2014 after a deadlifting workout. So I don't even think she was doing too much weight, probably not her max, but she had low back pain resulting from a deadlift. She had aches and pain. She pursued chiropractic treatment for 3 months and she thought that it was going to resolve. They told her like, oh, this would get better with time. It didn't. I think all they were doing was adjustments, no exercise involved. And now she kind of has occasional bouts of severe low back pain. And when she gets the severe low back pain, she has radiation into the right side, buttock and thigh, posterior thigh. She lives with constant pain in central low back. So it's pretty achy throughout the day. I don't remember what she rated that, but I guess that doesn't really matter. Bending, exercising, all those things, bending forward makes it worse, lumbar flexion. So you know where I'm going with this one, you know?
Mackenzie?
No. In November, she was doing a basic ab exercise. I have no idea what she was trying to describe. Did you know what she was talking about?
So not so basic.
Like basic bitches? Type
Maybe.
exercise?
She says like it was a simple ab exercise, but it really lit up my back. And she had some severe low back pain. It was around Thanksgiving, I think. And then that led her to do some imaging. So she got some imaging, got an MRI in January, and the doctor told her that she had the back of a 60-year-old.
Dun, dun, dun.
Dun, dun, dun. And I was like, that's odd.
I know some in shape 60-year-olds.
I know, like my mom. She's in
Exactly what I was
shape.
going to say.
She plays a ton of golf.
Yeah.
And is running
she
now.
runs.
Yeah.
Yeah, she comments on everything.
I loved it.
But yeah, so already I'm like, okay, is there part of this in her back pain because someone told her that she has the back of a 60-year-old? All right, let's get into a little exam. I gotta switch over. Any questions so far?
Not so far.
Mm-mm.
I think I know what's wrong.
You do? What do you think?
SOL.
I mean, kind of. What do you, I mean, it could be anything.
I don't know yet from history.
Okay.
I want to make my
I was going to
guesses after.
Yeah,
the
I
exam.
know all it should continue.
I would say if we're talking to our McKenzoid, I think I know, but I could. be
Heck
wrong.
yeah. Well, here's the thing. I doubted myself during this, so I'm going to call myself out. So are you guys playing? Oh, I thought you were playing Hangman.
I'm not sure what. I don't even know what this says.
Okay,
Alright.
back to my exam. Neuro was normal. Top tier was fine, other than multi-segmental flexion and extension were both painful. There was a severe loss of movement. Like she was arching back maybe like 10 degrees. Like it was not much. Single leg stance was dysfunctional. She's got a little bit of bunion formation, especially on the left foot. So kind of unrelated right now because I'm focusing on low back, but down the road, I'm going to be paying attention to that. Side glides were fine as far as movement wise. There was no pain with that. Slump was positive on the right. Straight leg raise was negative. Her hip mobility was pretty good in supine, just passively testing it. Sit up. So just having her lay down and do a simple sit up. I got that from you, which I think is super helpful. That was provocative. And then she was able to breathe diaphragmatically with coaching. So that was pretty cool. It was like she has done that before, which I don't think anybody had worked with her with it. Press ups produced no discomfort during, but improved her extension, her multi-segmental extension, but her back was aching after. So of course I'm like doubting myself. I'm like, okay, if it's worse after, let's just go the other way and see if it gets even worse, I guess. So I had her do supine knees to chest flexion and it was no change after. And I was like, you know what? 90% of people are going to respond to extensions. Let's just go back to it. We improved her mobility and extension let's just go with it. And then we did it again. She ended up feeling a little bit better after. So I sent her home with some dead bugs, press ups, and we went through some RDLs with I think we had a 40-pound kettlebell just to look at her hip hinging pattern. I mean, it looked great. We were able to do RDLs without any pain.
You did a 40-pound deadlift with a 60-year-old back.
Yeah.
Didn't explode.
And she was okay. She walked out of here with a smile on her face.
Why we have liability waivers.
But I called her the next day. That's what I've been doing with new patients, just to follow up with them. And I wanted to see especially how those press ups were going, since it kind of produced exacerbation of low back pain in office after that first set, but better after the second set. So I wanted to see how those were going. She seemed like the person that was going to be really good about doing the exercise and the amount that I told her to do. So I think I told her to do like a minimum.
Basing that off of her extensive
narrative that she brought you.
That
she was committed. She's committed.
Well, it's been for so long, and she wants to get back to doing CrossFit type workouts, and she wants to be able to do ultimate Frisbee tournaments without chronic low back pain. So she stuck with it. I think she told me that she did 6 sets throughout the day in the 24 hours since I've seen her, and she was doing much better. She's like, I haven't felt this good in a while. So we're going to continue going with that.
So it was a derangement.
For
all that fancy talk.
Well, I think something that we need to fill in the listeners. I wish they could see images. I wish they could see the pictures.
Oh, right.
Because she brought you the images, but when you were doing her exam, you had not looked at them yet.
Correct.
Right.
I didn't even want to look at the report. I peeped at it, but the report says there's like some disc bulges and protrusions, but the films looked great.
Yeah. I think she had just a little bit of scoliosis. Nothing to be overly alarmed about, but
it looked like a 27-year-old.
And I wasn't in the room. I just heard this through.
Did you fit her for a back brace though?
I did. We actually cast her in the office.
You better have put her in some custom orthotics as well for those bunions.
Yes.
But I could be wrong with this. Did the ortho tell her that she had a bunch of spurring as well? Am I wrong?
No.
Oh,
there
okay.
was facet hypertrophy.
Okay. Yeah.
Yeah. And then some moderate foraminal stenosis, but
yeah. We pulled up that x-ray and I was like, oh, this is pretty.
Yeah. I called her.
I hope I
she
had
was
that x-ray
so
at 60
happy to hear that.
Mine down
too.
looks worse than that.
I know. And you're only 59.
Look 25 though.
Oh gosh, I wanted to point some things out with that. Okay, so my thoughts with this patient. I did not meet her. I did not have the pleasure of working with her, but knowing that she brought in that complete narrative, from start to finish of everything she wanted you to know about her back. I bet you she's someone that if you could just show her pain, movements that challenge her without pain, it's going to give her so much confidence and it's going to really excel her healing and really improve her prognosis.
That's definitely why I wanted to
40
look
pound.
at her. Yeah. I wanted to see what her hip hinging pattern looked like. Is she capable of doing this without pain? Because who knows, if I told her just to do it.
And you're probably the first physician that actually sat there for an extended period of time, listened to her and watched her do these movements. Because she obviously doesn't have people that are able to sit there or willing to sit there and listen to her, because that's why she brought in that typed up long narrative of her history, because she doesn't trust that she's going to be in front of someone that's going to give her the time to go through it herself. So I applaud making her do the deadlift. I think that probably gave her a ton of confidence in you, and that only means improvement for her.
I just had a really strange thought. Follow me with this.
Yeah.
What if somebody typed something like that up because they had amnesia? I know she doesn't. What if they have periodic amnesia? Do you think somebody
short-term memory loss?
Do you think somebody could have chronic pain if they have amnesia?
It depends on what type of amnesia. I'm sure. If you have short term, then yeah, because you're just always.
I'm just saying, if something existed that you had periodic amnesia.
Would it be dependent on where in the brain was the problem?
Well, I don't know.
It's interesting.
That's part of the question though, right? Because then you're still thinking neurology versus subconscious, just kind of programming. I just kind of thought about that. It's weird stuff I think about all day.
This is a really good insight to Beau and I.
I'll also do this where it has no context.
None.
We'll be at dinner and I'll be like, what if dinosaurs still ruled the world? Like something weird like that. And she'll be like, where'd that come from? Or I really,
But it'd be even more obscure than that.
yeah. But that's a legitimate thought. If you
That
had
is.
loss of memory, like let's say somebody had chronic low back pain for 10 years and they have head trauma and they lose all memory.
Would they
Would they
still
still
have?
have pain?
Ooh, that would be an incredible
See, now you're
breakthrough
intrigued.
for
Oh,
research.
Stupid ideas.
Well, no
I
one's
wasn't
gonna
trying to
like
stupid.
intentionally give someone amnesia. Like, oh, you don't want back pain.
I know, but we got to find that person. We got to find that person because there's a person out there that has
But
battled
you
through
couldn't do
chronic-
it research wise, because if you did a knockout study in mice, you would be messing with like a specific like memory part of the brain versus like just like whacking the brain and think it's neuroinflammatory change.
You got to do a case. It's got to be a case study, like a retro case study. You got to
Probably
find that
exists.
person that
Maybe.
had an accident. They had chronic back pain and then they had an accident and couldn't remember anything before.
Well, and then if you had head trauma, like I know growing up, if I looked at my dad and said, hey, my head hurts, he would look at me and say, if I had a head like yours and it didn't hurt, then I'd worry. So that's probably what I'd tell that patient.
My dad would say, I'll give your head something to hurt. I'm kidding. He would never have done that. He wouldn't know.
Our next review message is gonna be from DCFS.
Not DC. What was it? Well, who left our last
Reb.
review? Rebs.
Oh,
DC Rebs.
DCFS. McKenzoid, keeping streak alive.
Every
Okay.
time you're like, you a case ready? I'm like, all of them
Will
are
you-
the same.
Next time we want an extremity McKenzie case.
Oh, I have one.
Of course.
Boom, bring it to the table next
It's an
time.
elbow.
There you go.
Also, I don't know if it's a NDS case, like neurodynamics. That's
Bring
a
it to the
question.
table.
Like,
There you go.
if someone walks in without symptoms in office and you can't reproduce it, do you just send them home with like a bag of tricks and hope something works, or you send them home with one thing and see if we get a change? Because I sent her home
I mean,
with two
that's-
things.
Really scenario dependent.
Mhm.
Yeah,
Like her, you mean like specifically?
the elbow that I'm
elbow?
talking about.
Jesus Christ.
Um,
The pig.
I get that's also other testing, right? It's
Yeah.
the derangement in the elbow because of scapular stability, all that stuff. Like, is anything else present? You know what I mean?
Those are tough cases for me.
Okay, I'll bring that one to the
Yeah.
table next time.
And we
Because
can
that's
chat
we were
about
talking
it.
about that in residency last night too, right? If I use McKenzie, like a low back derangement, if it's a restriction based issue, then we would typically think, well, that's probably a stability based problem, right? You're creating stiffness. So then it's like, well, if I just worked on that, what I have to do? So like, would I rather send that person home with McKenzie based elbow stuff or scapular stability or both?
Mhm.
Both is a safe play for sure.
Yeah,
Scapular
but
stuff's safe. The elbow stuff's a pain reliever, or could I get the same result, just scapular stuff?
It's
So-
always hard
If
for
that's
me.
the issue that they find, right?
It's always hard for me to say because like, who have I shadowed most ever in my life? Beau. And like, that's how he treats everybody. And so it's like, that's all I know.
Right.
And so I was like, do we need to change something? Yes. Does it take 3 things to do it? Maybe.
Right.
Let's do it.
And sometimes I do play safety. Like you had a little pain relief. I'm not sure. I'm sending home. This is what I know we have to change. That's why I'm sending
this
home.
is literally the exact conversation Beau and I had as we were falling asleep last night.
Yep.
Is
pillow talk.
yeah, our pillow talk was when to do McKenzie versus a DNS stabilizing exercise, and why not both? And he was kind of making the point of, well, maybe McKenzie isn't needed and you can just go to the stability exercise. Whereas I said, I don't think it's bad to give a person a dose of pain relief
I don't, but I was just saying.
Not that you
can
said that
still
was
get
bad
pain
either.
relief.
from doing the stability exercise.
Yeah.
I think that's experience. And you only know that through,
And there are people that
Experimenting.
literally, I mean, I would say like a knee. Like if I'm using McKenzie methods for a knee, I think that knee actually needs movement, right? Like it is so
Needs-
stiff. Like,
yeah.
you need to end range low because it may not even be getting to
End range extension.
full end range. It's getting to their end range right now.
Mhm.
But I'm trying to improve that. That's more often, especially extremity, where I'm using that and 100% going after it that way. Because I think that also does what? That improves function. I mean, that's why we get
Mhm.
knee extension, terminal extension, first thing post-op. You have to have that for like proper function around a knee. So yeah, I guess that kind of depends. Like, am I just somebody can get to end range improves pain? Right. In my opinion, especially an elbow in that case, I don't know the elbow case. That's, I would say most often not like how they're driving excess extension or flexion through their elbow.
Yeah, mainly one out the spine, so I didn't go to the elbow yet. I am very systematic where I'm always
Yeah.
central, peripheral, cutaneous.
That's
Not
not bad. That's not bad. And I think you can deviate that one of these days, but
Yeah.
that's in 2 years, 3 years, 4. That's in
Yeah.
my 1,000th
Yeah, you're
patient, my
building
2,000th
pattern
patient.
recognition right now.
Mhm.
Yeah.
Gosh, every once in a while, like I've got to go back to systems. When I came back from having Maddox and being on maternity leave, it was like, I felt like when I went in with a patient, I was almost in a tornado. Like I didn't have my routine like back again. So I had to kind of go back to the basics of here's my systematic approach.
All right.
Okay, I've blabbed enough even without a case.
Very good. So my last one's a bit different. I don't have the classical case presentation because this is a virtual consult or virtual client. So this is a 32-year-old male that is, if he's listening, I'm gonna say pro golfer. If he's not listening, I'm gonna say trying to be a pro golfer. He would agree with that. He is his.
Gonna hear both. So.
He is his heart like biggest critic. And he's always like doing it in a poking fun way. Like everybody that I've always been to tells me that I'm not great, like stuff like that.
Maybe
But it's
that's
not.
his biggest problem.
I don't think it is.
Okay.
But we'll get to that.
He thinks that cervical rotation.
So anyways, there's a long story behind this. And again, this isn't like clinical data sets. Yeah, we go through on virtual consult. You have to do a much more extensive history because you're not hands-on. The gist of his story was that, and I think about 5 years ago, he was playing in a mini tour. He stepped in a hole while he was carrying his own bag. Because you're carrying your own bag those events. Sprained his ankle pretty severely. Played the rest of the tournament, and then after that, just started having all of these problems. Right, obviously ankle problems, pain around there. Golfers are notorious for, or any pro athlete, like stuff just feels different, right? But he started having some low back stuff, and just everything started changing his game to the point where kind of almost, in my opinion, became a little hyper aware of stuff, right? Like my ankle's not great. Now my hip doesn't move right. And then started working with people that were trying to help from the coaching end, right? All the way from like some of the best people in the coaching business that are using a lot of technology on the golf end to some of the biggest names in our profession. This guy was actually a case that was presented at the World Golf Fitness Summit in 2016, so over 2 years. I think it would have been 16 when we were there, which would have been
New Orleans.
Yeah. Which I didn't know at the time, but he was on stage with Greg Cook as he's presenting this case. So they were kind of going over what all had changed through, the FMS, SFMA system around this ankle problem, because, and this is coming from Adam now, the client, that he couldn't clear basically a lower quarter, like Y balance screen on the right, like regardless, like he would improve, but then wouldn't be able to clear it. So they just keep going after this stuff. And he goes, I would hit improvement. And they were doing a lot of like lower level developmental stuff, right? Like quadruped, half kneeling. He said that rolling tended to be like a consistent thing that would like come and go, right? So he's doing all this stuff with a great guy down in Orlando. Well, he doesn't live in Orlando, so that was part of the problem. So he was going back and forth from Arizona. So he starts just kind of like going on a journey that I think a lot of people do. But then when you have more access and money and you're going to like the world's best, so ends up with some different PTs and chiros and different practitioners of like LDOA and DNS, and then high level like podiatrists. And by the time he sees me, I was kind of a filter, right? He's telling me everything's done, and I'm trying to like determine like, well, that has merit, this doesn't have merit, right? That holds water, all this stuff. So one of the things that he did point out, obviously he's had these ankle issues for a long time, is I was like, well, I need to see your swing. So I'm going to put, if you're watching this on YouTube, if you're listening, I suggest you go watch the video. I'm going to put up these videos in a split screen that he just happened to have video of him swinging, I think when he was in 8th grade, when he was in college, and then obviously now. So remember, he had this injury and he's like, I can't get around my right side. I can't get this to happen. We go back and watch his 7th grade video, which I'm just pulling up so I can look at it right now. He never got around this right side. So if you're just watching with me right now, he never externally rotates his tibia, gets into his back hip, never. So then you fast forward to college, Same thing. So these are both prior to the injury, obviously. College, his right foot, now he's in flip-flops, which is not a great read. But again, we're watching this here live. He never moves his right knee back into a load position at all. He's lucky he's as mobile as he is, which is probably what's led to some of the cervical rotation stuff. And I don't know how much, we'll talk about that in a second. Anyway, still a pretty good golfer. And I'm going to put these videos up so you can be watching as we're talking here. And then we watch modern day swing. It looks the same. So I quickly pull out, I go, nobody's ever drawn that conclusion that your swing's always been like that this isn't like secondary to an ankle injury. He goes, nope. I mean, we're talking like best in the field golf coach wise. Always kind of interesting when you're like, seems like a pretty simple thing. And I just asked a question, do you have old video? Yeah, I'll happen to. So that hasn't changed. So that kind of opens up like, well, that doesn't mean that that's not, I think you do need to load your back leg in a golf swing. Why aren't you doing that? So then he brings up that he saw Emily Splickle. You know who that is? Pretty good foot doctor. He goes, she said something, and he didn't know how to explain it. He goes, she said something about my ankle not being formed right. So I'm like, And he goes, yeah, she said something like it doesn't want to move a certain direction. So that's kind of like an ankle equinus, right? Like the formation of the talar dome can be, you know, one of the three kind of knuckles isn't formed quite right, and you won't have rotation or adequate dorsiflexion. So I was trying to send him with a PT in his local area, and I go, you know, that'll be the hands-on. And if he thinks the same thing, then I would, you know, kind of agree with that, because if you can't externally rotate your tibia against your talus, you aren't going to be able to do the movement that we're looking for.
Yeah, because of bony change or bony development.
So I tell him that, and then he goes, well, you know, what's interesting is she wanted me to use this wedge to put under the inside of my foot, because I started thinking like orthotic stuff. And he goes, yeah, she gave me this wedge to do exercise on. And I was like, yeah, that's, you know, a varus post, right? We're going to rock your foot out into kind of supination. So then he has this wedge sitting on the back wall. So he gets up, and I have him do a squat without it a bunch of times and do a squat with, just swinging wide open. We're talking these little wedges we have over in the corner, just, you know, a little, I don't know how many degrees is that, 15 degrees or something. So then I go, hey, can you just practice hitting a golf ball with that wedge under your foot and see how it feels? So he goes out the next day, showed me like night and day. Now that's going to have ramifications, right? If he just goes out and starts doing that a lot, he's never done that before. So he starts working with his local PT that I set him up with that I think's stud. They're working on some hip stuff. He's feeling better. He's starting to do some, I told him, hey, don't go to the range, just hit a bunch of balls, like do a bunch of drills on these things, you know, whatever your PT does. So then he meets back up with me and he says, hey, I think I want to get orthotics, because we said, hey, maybe you need to have something in your shoe to do this all the time if it is morphologic, right? So he goes to our friend, Cam Kabari, that's in Arizona as well. So shout out to Cam for helping him out, who also uses Sean Eno, who is a stud. They fit him for orthotics. He hasn't gotten them yet. So then that was our latest meeting that we're talking about, hey, when you get to orthotics, how are we going to break them in? How do we get them up to like golf level? So while we're on this last call, which was just this past Wednesday, he's always reviewing his story, because it's like you can tell he's trying to play detective. He's like, it just seems like something, like I'll start playing golf for a while and like tighten up. If I start working out, I like hit a point where I feel good, then I do too much and I like tighten up again. And he's like, I've worked with all these people, and he goes, Eldoa seems like I go into like, and now he knows all the lingo. It's like Eldoa seems like I just do like high threshold stuff, and like I seem to be high threshold all the time. I do DNS, but then I hit a limit where there's no more change. I've done just strength training, but then I hit a limit where I don't, you know, all this stuff. And I was like, there may be something missing, or you're not programming all that stuff right. Or you're just doing it piecemeal. You do it for a little bit and quit. So his biggest thing that he was complaining about at this point was he sent me a top tier SMA video, which I'm going to put up in this video. And he's going through some stuff. There were a lot of things that weren't awesome, right? Single leg balance wasn't great. Deep squat wasn't awesome. Multi-segmental flexion and extension, not great. When we're looking at a athlete, in particular a rotary athlete, the biggest things we're looking for is asymmetry. So even though all those things weren't great, they were bilaterally deficient, right? Single leg stance, rotation, all that, or flexion extension. The asymmetry was in cervical rotation. It was pretty apparent. So I just gave him, I said, hey, I'm going to have to give you some exercises that are tests, and then you video and see what happens. So he had I would say a right decrease of right rotation of probably 20 degrees or so, maybe more than that. And he just said it felt tight, no pain. Left is completely wide open, probably a little bit beyond 90. And remember, he can't, for years, over 2 decades, has not really access his right hip, right lower quarter. So where is he going every time? Left rotation's been just like patterned massively into him. So I give him loaded cervical rotations. That comes from kind of like the 4x4 SFMA stuff. You lay on the ground, you have your arms pressed out against the TheraBand, and then see if they can go through rotation by kind of eliciting a core reaction. That didn't change anything. So then I was like, let's look at your eyes. He does like 5 convergence, or, you know, following your finger into convergence with his left eye covered. His neck snaps into right rotation fully. And he just sends me a little message on our app. He's like, this is pretty spooky. And I think somebody read it in here, and I just wrote him back and I was like, we struck gold. Now that may not be a like, oh my gosh, that's our thing. But that could either be a finding or that could be a jump off point for treatment, right? That you're patterning neurologic response, or that neurologic thing is driving the bus here. I wanted to bring this case up, not to be like, oh, we found this fancy thing that increased rotation. I think we're going to like change this guy's life. The whole theme of our last talk was, and this is what he kept asking, he goes, why isn't anybody putting all these pieces together? Why isn't anybody like giving me all this stuff? And I was like, not very many people, as we said this on the residency last night too, not very many people, in my opinion, are good at looking at a human. They get trained, PT, chiro, that's one set of training. Methodologies, that's another level of training. And then you have your own biases, right? Your sports that you're involved with. We kind of get funneled from this, like, we're treating humans instead of I'm a chiro that does DNS, McKenzie, neurodynamics that treats runners. And pretty soon you have a really narrow, even though you're like, I'm really good, like it's still pretty narrow, versus like, are you looking at a human, and a human's made up of, you know, trillions of cells, multiple systems. Like, can you actually look at somebody from all of those and then determine what needs to be worked on, and then be confident enough to pull the trigger on the thing that needs to be worked on, especially if it's outside of your realm, and then have a good referral, or, you know. So I should have a cool little video follow-up on this guy, because he's going to come hang out with us for a week, and we're going to get to work here and like dig into it. And I told him on the call, I was like, I can't promise you anything's going to be different than what you've done before, right? It may be the exact same stuff, and you just, like I said, you've never programmed it appropriately. Time may not have been enough. I don't know, but I really don't know without an exam. So yeah, I just thought it was interesting that if somebody like this has worked with like people that I look up to, there's either, it could be the person, right? It's like a Tiger Woods. They may be searching, and no matter what they find, they're going to keep looking. Or there is some like dot that's missing. And I'm pretty sure, I need to look this up. I should have looked it up. If it was Yami or Yager that Kolaj worked with, I'm pretty sure it was Yager. Mm-hmm. The story there is that he'd had like I think it was right adductor pull pain, whatever, like repeatedly for, I think, over 2 years, to the point where he was thinking about retirement. So he had been with numerous practitioners, all these people, looked at everything under the sun, all the way down to like, you know, blade angle, all these things with skates. And then Pavel Kolaj comes in. I know this is like a, you know, sixth hand story by this point, that it was like 10, 15 minutes. And he's like, you have a malocclusion thing going on, and you need to be fitted for a bike cart. And that's what it took. That was the catalyst for like complete change. Now, there's a lot of things that could have been going on there. Was he so confident in telling him that was like a huge part of what was happening, or was that truly a finding? I mean, there's a lot of things at play there, but like that guy went on to keep playing and not have problems. And it was something away from the issue, wasn't even in the same system technically, was out of that practitioner's realm of treatment also. So I think that's what I'm kind of aspiring to be, is somebody that's going to be able to like go into a scenario, look at anything, determine what it is. And I think that's being a diagnostician or a physician, not just like a chiropractor, a PT, MD. Like, I'm dealing with humans. Humans are pretty complex. So.
You, I think, sped through this point very quickly. So I know if I were listening to this, I would have went, wait, what did he say?
Trying to stay under my 10 minutes.
Yeah, you did great. So I'm going to lengthen your case study here.
Are you saying like 10 minutes? I don't know. I don't know when I started.
Well, you said that he went through those eye convergence exercises and his neck snapped into left rotation. That's kind of the sentence that you said. I just wanted to explain, because you may not be seeing a video to go along with this.
Well, they will be when they're watching.
Well, someone could be listening to the podcast.
Well, they need to stop their car, pull over and watch video.
Pull up the YouTube channel.
Great.
Okay, so
And subscribe.
when you watch, are we at 10,000 yet?
No, it's
Or you? His left rotation before the eye convergence. right rotation before the eye convergence exercises was quite stiff, like you said, about 10, 15 degrees shy of
And
where
like
it should have been.
fighting to get where.
Yeah,
it
like
was,
he was trying, he's an athlete, he's trying to get there. And then you could tell after he did those exercises, the eye convergence exercises, when he went into his right rotation, it was almost like he expected it to stop, and it didn't stop. It was like, I'm rotating my head and then it just whoom, like whips through way past his stopping point before. So it was kind of neat to see him, like I said, expecting that stopping point and then just bypassing it. So I just wanted to make sure that that was really understood.
And that is a poorly understood thing. Even, well, here's another interesting point though on this. In the beginning of the conversation the other day, he goes, "Hey, I wanted to ask you a question." This is before we brought up any of this eye stuff. He goes, "I wanted to ask you something, like, is this Z guy any good, or is it weird, like pseudoscience stuff?" I go, "Z health?" He goes, "Yeah." I was like, actually, that guy like kind of got like downplayed for a long time. And now he's actually being, you know, validated by pretty much the entire, you know, field. And I go, that's some of the stuff that we use in the clinic that I do think helps us have different jump off points. So it was really ironic that that's kind of the thing that saw the biggest change. And then he's bringing it up, which then there's another internal validation for him that he had bought the Vision Gym. He just never used it. Probably because he didn't know how. I mean, can you imagine being layperson buying the Vision Gym being like, well, what am I doing here? Like,
When you probably do it once a day, like you're not going to see
right.
much change like you're supposed to.
So take him, for example, say that right rotation really stays with him. How much is that going to change his golf swing?
And we don't know. And that's why I told Monica this, and she goes, really? Like his exam, if he comes in, like we're going to spend 3 hours. That'll be a lot of treatment too.
That's what I spend with a gymnast that travels out of
But
town.
this is a pro athlete. Like it could be longer.
Yeah.
It's like Cobb. I mean, he spends, I can't remember. It's a long time.
Like the exam will be treatment like anything. So there'll be a lot of stuff we'll be working on, but like we will explore everything. And I mean, a lot of it's going to be history, nutrition, like environmental stuff. Like we won't even start doing things for almost an hour.
Maybe like uncover some adolescent traumas, that kind of stuff.
I'm just thinking, like, what if you have to pee?
You just take a break.
Now I'm taking notes on hydration status and urinary bladder.
I'm gonna need to see that color.
But yeah, I'll give you an update, like hopefully shoot a bunch of content when he's here, but also just kind of like keep you updated beyond that. So I also think having the orthotic in, once he gets that from Eno, is going to be huge.
Mm-hmm.
So.
What I think is ironic is that you gave him end range movement of the eye and you improved cervical rotation.
McKenzoid.
Is it a concept? I don't know. End range movement.
Could be. Well, and again, the things that we think are common or kind of common sense, when I was trying to explain, and he kind of knew it or he wouldn't bought the Vision Gym to begin with, but I was trying to explain why we were going to do that. And I go, you're going through right eye convergence as you look at the ball on your backswing. And he was like, oh, it's like, how is nobody like talking about this stuff? Right? TPI has a vision screen in it. That's like the last level of the TPI screen. So just like, again, it baffles me because I'm thinking this guy's been with people that are like very high level. And I would assume, right, that you think they do that, but it's also the assumption I made when I went to the Olympic Training Center, and you just make those assumptions enough. And then you're like, oh, you got to quit assuming and like you be the person that does it at the best you can. And, you know, then you'll get sought out. So,
but that's like one thing I'll say about this exam, which I feel like you downplayed, super humble about the whole first part. When we first talked about it, how many things you asked him, and he's just looked at you and just like, well, why hasn't nobody told me these things, or why? And like, you haven't even got to put your hands on. Like, you think like everybody wants to jump to hands on and they won't ever just talk to the person. And it's like, you just ask the right questions and then you're able to put your hand on, hopefully.
What leads you so much.
Yeah.
Like when he comes in, I know that like, I'm kind of like the first thing I want to feel is your ankle. Right. And then we need to do a bunch of vision screening. Obviously we have a ton of stuff to do, but I'm like, I have to rule that stuff in or out because we've already seen that's where the most work needs to be done or has been done. Mm-hmm. And then we can go explore a bunch of other stuff.
You guys are sitting at a table with someone that doesn't even move from her stool for the first 52 minutes of an hour-long exam.
That's Sloan. Like if I'm running behind, like I'm like, crap, like I've got to hurry up, like still provide hopefully super good care And Sloan, she'd be 30 minutes behind. I'll walk past her room. Her legs are crossed. She's leaned back against the wall, just listening. And I'm like,
How is she so calm?
world-class.
Which becomes the bane of my existence sometimes.
Yes.
Or you have
Yeah.
to trade off with Maddox sometimes, and someone will be like, I'm done. She'll even sometimes be like, I'm done at 11:30, but it's somebody that I'm going to be talking to for a while. It's playing at 11:45. I've come in like an hour later and she's like, I'm just finishing up. I'm like,
I'm also someone that will squeeze someone in if they show up and they didn't have an appointment. Okay, we're gonna make it happen.
Yeah.
Like,
But you also strategically put those
I do.
people at the end.
yeah.
Or when you
I
have
hope I
time.
try. There's days that
Yeah.
doesn't happen, but
Yeah.
I have my people that I frequently tell them that I get as much out of the appointment as they do. I connect with
It's
a few
also
people.
just the power of having somebody listen to you,
mm,
especially when you're in pain. I mean,
Yeah.
in some of those cases, they're not, they just want to chat.
yeah.
But I mean, if you just let somebody talk about what's going on,
That's what-
sometimes they
that's-
feel better.
That's what I think is so great about your case.
Yeah.
I mean, I think it's clear that she has not had anyone listen to her, and that's why she wrote all that up for you.
yeah, I'm going to paint eyeballs on my eyelids. Yes, I'm listening. Oh, what was that? Oh, no. I think we're all really good at that. I mean,
Yes.
I think in our field overall, we're getting better, and most people know that. But there's still that subset, even of the people at the top of our field, that think that that the history is not worth a whole lot, right? That you're getting a bunch of information that they're
clouds
leading,
you.
well, that they're leading you where they want you to go, right? Well, there's some really damn good interrogators and lawyers that you can ask. We could all ask the same question. What you pick up from the answer is totally different based on body language, how they said it, the other lines of questioning, right? I brought him up on the podcast, right? Joe Navarro, the FBI interrogator, all these people are like really telling you, like, you're not just listening to the words out of their mouth. Like, it's all these things, which I was just looking in his book again to look for a quote. And he had a part in there where if you can't see Monica and I's lower half, you have no clue if we're telling the truth or not. Just based on what our feet are doing, what position they're in, do we change position when we tell you things? So then there gets to be like, say I was behind a desk doing a consult with somebody, there's already a level of distrust.
Yeah.
Versus we're in an open room, we can see what both are doing. I know that seems weird, but like, it's little stuff like that makes a huge deal. And then you think about like virtual consults, and I've explained this to people, like, these are tough, right? Because it's not the amount of buy-in you would get. I don't know what I'm seeing. Like, yeah.
You can't see their lower half.
Or,
What are you doing with those toes, man?
Or if you
I mean,
can,
people do their
it's skeptical.
consult like this now. All right, any last words here? I mean, it sounds like we're all dying. I mean, any like last things you want to say?
We'll see you in 2 weeks.
Okay. Out.